Hello student. Good afternoon to all of you. I hope I am clearly visible and audible at your end. Just give me a confirmation that I am clearly visible and audible. Hello Dr. Kumar, Dr. Rahul, Dr. Sani, Dr. Brinda, Dr. Diksha has also joined. I hope I am clearly audible and visible to your side. So today we are going to discuss some clinical oriented MCQ, around 20 clinical oriented MCQ exclusively from physiology, and these questions are the part of the PrepLadder clinical question bank, right? So good afternoon to all of you. Dr. Subhangi, Dr. Shishir, Dr. Devi, Dr. Safiq Mohammad and all others. Good afternoon to all of you. Lagging will be there a little bit but I think you can refresh your page and try once again, right? So we are going to start the session. Fine, just give me a minute, right? So we are going to start the session immediately right now. So here we are going to discuss 20 clinical oriented MCQ from physiology. You will get to know that how the clinical oriented MCQ will be asked from the subject of physiology, because you know whenever we ask about the clinical oriented questions, we mainly think of the medicines, surgery or other related subject. But question can be framed from the physiology subject also, and the question will be pure clinical oriented, but obviously the questions will be based on complete your physiology knowledge, right? So those type of questions we have kept in this session. Some of the questions are easy, some of the questions are a little tricky. So first we will try to answer those questions and then we will discuss the answer in a crisp manner. Okay, detailed discussion we are not going to do because that sometimes can be boring in a YouTube session, right. Good afternoon. So now we are going to start the session directly, right? I hope all of you know me. I am Dr. Soumen Manna, your physiology teacher of PrepLadder team, right? Namaste Dr. Prabhat and all. So we are directly starting the session. First questions coming in front of you. So first you read the question. Question is, a 65-year-old male patient presented to the emergency department with acute chest pain, right? And you have done one electrocardiogram. Electrocardiogram is showing ST segment elevation in lead 1, lead 3 and AVF. So obviously you are understanding that the question is about the myocardial infarction, acute myocardial infarction. Yes, obviously the first year and second year question, subject are also very important for next or whatever type of exam you are thinking of, right? So now you look at the question. Although the questions is clearly indicating that it is a question of myocardial infarction, the patient is suffering from acute myocardial infarction, and particularly the ST elevation is lead 2, lead 3 and AVF. So probably we can guess that it is an inferior wall myocardial infarction, but the question is not about that. The question is something different, right? So question here is asking which of the following cellular process is primarily responsible for rapid depolarization of the ventricular myocardium. So read the question carefully. They are asking about the rapid depolarization and ventricular myocardium with every heartbeat, right? So you have to understand that ventricular myocardium, whenever it is generating action potential, right? For every action potential, there will be one contraction, one heartbeat. Okay, they are asking that rapid depolarization phase of myocardium action potential is due to which one? That is actual question here, getting my point? So first you read the question and then you try to jump on the answer, right? So like for example, some of you are answering option number C. So this option number C cannot be your answer. Potassium efflux through the voltage gated sodium channel. What is this? This is responsible for repolarization of the ventricular myocardium action potential. All of you know that the action potential of the ventricular muscle looks like this, right? And here which phase is known as the rapid depolarization phase? That is the phase number 0. So this is the phase they are asking about, and rapid depolarization phase is phase number 0, and we all know that phase number 0 is due to rapid entry of sodium, rapid influx of sodium into the myocardium cell. So the answer to this question is direct, that is a sodium influx through voltage gated sodium channel. Sodium entry occurs through the myocardium through voltage gated sodium channel. It is not the ligand gated sodium channel. So, ligand gated sodium channel is also not my answer, right. Question is blurred. Okay. So, check once again. So, the question is asking about the ventricular depolarization, and that is the rapid depolarization. So, I hope all of you can understand that the answer to this question is option number A, that is the sodium influx through voltage gated sodium channel, right. Now, I hope all of you remember that whenever we talk about the action potential of the heart, there are two types of action potential. So, one is the myocardium action potential. So, this is the typical myocardium action potential which I have just shown you. And second type of action potential, as you can see here, this is a kind of nodal tissue action potential, nodal tissue action potential. So, if you look at the question is not about the nodal tissue action potential. Otherwise, nodal tissue action potential is due to entry of calcium into the nodal tissue cell, like SA node, AB node, right. So, all of you know. So, the nodal tissue action potential. So, two take home message from this question. One is, if the question is asking about the nodal tissue action potential, what is the ionic basis, then it is the calcium, right. And if it is a question of myocardium, then it is the sodium which will causes action potential in this two tissue. So, the detail I am not going to discuss here. Okay, different phases are there, different phases has different ionic basis, but at least you take this message to your brain that if the question is about myocardium action potential, then it is the sodium entry through voltage gated sodium channel. If it is the nodal tissue action potential, then it is the calcium entry through L type, long type voltage gated calcium channel. So, these two things you should keep in your brain. Okay. So, based on this, we have answered the question. That first question answer is option number A, that is the sodium entry. Now, we are going to the next question. So, the next question is here. Read the questions carefully. So, again a clinical oriented question. 45-year-old male patient presented with fever, headache and stiff neck, right. Lumbar puncture reveals increased white blood cell count and elevated protein level in cerebrospinal fluid. So, looking at the question, first thing that is coming into your mind that the patient is suffering from probably meningitis, right. So, this fever, headache, stiff neck along with the increased white blood cell count and the protein in the cerebrospinal fluid indicate it is a meningitis. So, meningitis, what happens, there will be breakage of the blood-brain barrier and the bacteria or the virus will enter into the cerebrospinal fluid. That is the basic thing. So, now the question is asking which of the cellular structure is primarily contributing to the blood-brain barrier. So, in my lecture video, I told you repeatedly that the blood-brain barrier, if it is question is asked that the blood-brain barrier is formed by which cell, it is not the astrocyte. Your answer should be it is the single layer endothelium cell of the brain capillaries. So, there are capillaries in the brain and spinal cord. The endothelium cell will line those capillaries. So, the endothelium cells, and in between the endothelium cells there will be tight junctions. This will make a continuous layer, continuous barrier, and that continuous barrier will be known as the blood-brain barrier. So, if I draw a schematic diagram, suppose this is the endothelium cell of the brain capillaries, two endothelium cell. In between these two endothelium cells there will be presence of tight junctions molecule, and now it is forming a complete barrier, and this complete barrier is known as the blood-brain barrier. So, please note down, blood-brain barrier is formed by endothelium cells along with tight junctions. Astrocyte, the food process of astrocyte, is also there in this barrier. But the food process of astrocyte is not for the formation of the blood-brain barrier. It is there for the regulation of the permeability of the blood-brain barrier. What I told, it regulate the permeability of the blood-brain barrier, means which substances which penetrate through this barrier or which will not. This decision will be taken by food process of astrocyte. That's why we say that it's regulate the permeability of the blood-brain barrier. So, that is the basic thing that you have to remember here. Now, if you look at the question, many of you have given the correct answer. So, the tight junctions is the correct answer in these questions, right. Now look at one diagram which I have taken from the journal article. So in this diagram, what you are finding out the structure of the blood-brain barrier. I will show you. Look at this. So this is one endothelium cells. So you can find out this is one endothelium cells. This is another endothelium cells, right. So in between these two endothelium cells, so this is one endothelium cells and this is another endothelium cells. We can easily find out that in between these two endothelium cells there is presence of these tight junctions. There is presence of these tight junctions, and it is making a complete barrier, and this barrier is known as the blood-brain barrier. So you can also find out the astrocyte here in this picture. So this is the astrocyte, and I told you which part of the astrocyte. This is the foot process of astrocyte. What functions the astrocyte is playing here? It is regulating the permeability of the blood-brain barrier, right. Now you have already understood this picture and diagram. Now look at, there are 5 things written here. So one here it is written, number 1, paracellular aqueous pathway, second transcellular lipophilic pathway, third is the transport protein mediated, receptor mediated transcytosis, and adipocyte absorptive transcytosis. So these are the various mechanisms by which certain substances or all the substances, how they penetrate the blood-brain barrier, that has been shown in this picture. So look at here. So the first process, some of the substances can penetrate through the blood-brain barrier through this paracellular pathway, that is the first pathway. Some of the substances can directly enter through the cell because they are the lipophilic substances, lipid soluble substances. We all know that lipid soluble substances can easily penetrate the blood-brain barrier by the process of simple diffusion, right. So the second process is simple diffusion process. The third process is the transport protein mediated. So there will be presence of certain transport protein that will transport certain substances, like for example glucose, amino acid, nucleic acid. So this glucose, amino acid, nucleic acid, how they are penetrating the blood-brain barrier? With the help of certain transport protein, carrier protein, right. The fourth process is the receptor mediated transcytosis, right. So the receptor is attaching with this transporter substances, and then the receptor is engulfed, and then it is penetrating through the cell, right. And the fourth process is adsorptive transcytosis. The substances is penetrating through the cell cytoplasm by the process of adsorption. So there are 5 processes by which any substances can penetrate through the blood-brain barrier. Why I am discussing this? They can simply ask you that what is the most common pathway for transport of various drugs or medicine through the blood-brain barrier. Remember, the simple diffusion is the most simple diffusion is the most important process, most common process for transport of various drugs or medicine. That is the simple diffusion or transcellular lipophilic pathway. So the difference between this fourth and fifth is that in the fourth there is presence of some receptor. That receptor will attach with the ligand, and the whole receptor ligand complex will internalize into the cell. But in the fifth process, such receptor is not there. The substances is directly taken up by the cell, right. So that is the difference between these two processes. But please remember that among all these 5 processes, right, the second process, that is a simple diffusion or the transport through the lipophilic, transcellular transport by lipophilic substances, that is the most common pathway for entry of various medicines or drug into the blood-brain barrier, right. And if the question is how the bacteria is penetrating the blood-brain barrier, causing this meningitis, then your answer will be this transcellular process, So this paracellular process and this transport protein mediated transcellular process, they enter. So if the question is how the bacteria is entering, so either it is by paracellular disruption process or by transcellular process. So they can enter, bacteria or certain virus, they can penetrate the blood-brain barrier, they can disrupt the paracellular transport process, means this tight junction protein will be disrupted, or it can directly enter through the cell by disrupting this process of this transport protein mediated pathway, or maybe the adsorptive process, right. So para or transcellular both can be disrupted by various proteins, virus, which are causing meningitis, right. So if I go back to this question, the question is very simple. The question has given a clinical presentation of a patient of meningitis, and the question is asking what structure is forming the blood-brain barrier. So 2 important things, endothelium cell and tight junctions, and astrocyte regulate the permeability of the blood-brain barrier. Most common process by which substances penetrate the blood-brain barrier is simple diffusion. So these are the take home message for this question, right? Next question we are going. So this is question number 3. Very good. I hope you are understanding. So now the question number 3 is here. So this question, a 45-year-old male presented with muscle weakness and dysphagia. Very non-specific symptoms. There are various disorders. Next is saying that reveal antibody against striated muscle protein. This is also a non-specific. Striated muscle protein against antibody. Which component of the striated muscle they have not specified, right? So this kind of symptoms can be in various disease order, including even the myasthenia gravis can also present with this kind of symptoms, right? But question is not related to this clinical presentation, although the question is directly asking which of the following cellular structure is primarily affected in this patient. Now I will say that the question is pretty much simple, because you are directly giving hint in the question itself that the antibody are directed against the striated muscle protein. So muscle protein myocytes are damaged because the antibody are directed against them, right? Which component of the muscle protein, that it has not been given here, but we can simply answer the question by only looking at the presentation of this question, right? So antibody are directed against striated muscles, so which component is going to be damaged? Obviously the myocyte or the muscle protein, right? Myocyte or muscle, right? So direct answer to this question is myocyte, right? So we cannot reach to a diagnosis only by looking at this clinical question. So we are not going into detail of that. So the simple answer to this question is myocyte or muscle protein. That is question number 3. Now we are going to the next question, that is the question number 4. Again you read the question and then try to answer. So here a 40-year-old male presented with constipation. He is taking medication that acts as an muscarinic receptor antagonist. So from your pharmacology knowledge, you know that anti-muscarinic drugs agent, they causes constipation. So what is the cause of that? We simply know that the anti-muscarinic agent, they are going to cause decreased contraction of the smooth muscles of the GIT, right? Now, if you look at the options now, one of the options is very easy to choose as an answer. But if you critically look at the other options, they are also very closed option, right? So you are giving correct answer. Yes, I am getting correct answer from many students here. I can find out that anti-muscarinic agent means they are going to block the receptor for acetylcholine. Okay? So simply answer here, the answer is E. It blocks the binding of acetylcholine to its receptor. Correct answer. There is no problem. That anti-muscarinic agent up there means what they are going to do? They are going to block the receptor of acetylcholine, right? So now you look at the other option. Okay. So what is the reason of this constipation? When I search the literature, what they are saying is that, look at here. So M2 and M3 are the main muscarinic receptor that is responsible for motility or contraction of the GIT muscles. Okay. So M2 or M3 receptor predominant, and under acetylcholine stimulation it increases the motility of the stomach. So whenever you block this receptor M2 and M3 receptor, okay, in the anticholinergic reaction the motility slow down, which can result in gastric stasis and constipation. So whenever you are blocking this M2 and M3 receptor, what is going to happen? Obviously the motility is going to be decreased and it is going to cause constipation, right? So basically you have to understand that which are the main receptor which is responsible for this constipation, M2 and M3. Now if I look at the molecular mechanism of this M2 and M3 receptor, then other options which has been given here, they has to be considered before directly answering E, right? Although E is a correct answer, I am not saying that, but whenever you are jumping onto an answer, before jumping onto that answer, also understand the other options. So look at, if I look at the M2 and M3 receptor, could you tell me what is the molecular mechanism? Means they are G protein coupled receptor or they are ionotropic receptor? Okay, yes, that is I am showing here. So M2 receptor here, look at this table. This table are showing all the G protein coupled receptor, one of the very important table in your exam. G protein coupled receptor, all the G protein coupled receptor maximum, right? So G protein coupled receptor, all of you know that it can stimulate the G protein, they are known as the GS, right? Here it is given GS, and it can also inhibit the G protein, which is known as the GI, right? So apart from GS and GI, you also know that there is another type of G protein which is known as the GQ. So this GQ is connected with the phospholipase C, and through this phospholipase C, it produces a second messenger, that is the IP3 and DAG. Now this IP3 releases calcium from the sarcoplasmic reticulum, and DAG, it stimulates the protein kinase C. Getting my point? And what are the receptor, muscarinic receptor that act through this GQ phospholipase C? They are the M1, M3, M5 receptor. M1, M3, M5 receptor, right? So if I go back, M3 receptor is also a causes of constipation, but that is not the main one. Main receptor which is responsible for constipation, that is the M2. Otherwise, if M3 is the main receptor, then what the M3 will do? M3 will stimulate the GQ, okay, M3 will stimulate the GQ. GQ will stimulate the phospholipase C. Phospholipase C will produce inositol triphosphate and diacyl glycerol. Diacyl glycerol will stimulate the protein kinase C, and inositol triphosphate will release huge amount of calcium from the sarcoplasmic reticulum. That means if I block this M3 receptor, all this process will be reverses. That means if you look at this option number, inhibit calcium release from sarcoplasmic reticulum, that is also possible if the receptor is M3, right? Activate protein kinase C. Activate is not possible because if you block the M3 receptor, then there will be inhibition of the protein kinase C. But look at, these two options are also related to these questions, right? So that's why these two options has been given, that if it is the M3 receptor, then M3 receptor blockage means you are also inhibiting the release of calcium from the sarcoplasmic reticulum, you are also inhibiting the protein kinase C, okay? Other option, these two are not related to this molecular mechanism, right? So obviously we can easily choose our answer, that is the answer number E, that is the correct answer. But I am saying that this is correct answer because it is directly saying that antimuscarinic agent will block the acetylcholine receptor. There is no problem in that. So this is absolutely true statement. But suppose this statement is not there in your question, then you can go for this option number A as your correct answer in this question. Getting my point? So all of you tell me whether you got it or not. Decreased muscle contraction, yes, Dr. Roy, that's why I was telling that option number A can also be a correct answer if this last option is not given. That's why we are discussing this whole thing, right? So please remember, M2 is the main receptor which is causing constipation here. That's why we are not choosing the option number A is the correct answer here. But if the option number E is not given, then A can be your correct answer. Okay, got it, fine. Chalo. Next question we are going. So next question is here, that is a question number 5. Okay, here a 45-year-old female with a history of hypertension presented with palpitations and ECG shows wide QRS complex with a heart rate of 150 beats per minute. So whenever you are seeing a ECG of wide QRS complex with a heart rate of 150, you know the reasons, you know more than me because you are reading medicines. So wide QRS complex tachycardia. The first thing that comes to our mind is typically monomorphic ventricular tachycardia. It may be supraventricular tachycardia with aberrant condition also. So yes. So look at here. Yes, so the first thing that is coming to your mind is the ventricular tachycardia, okay. But if you look at books that what are the causes of wide QRS complex tachycardia. So these are the all causes of wide QRS complex tachycardia directly given in books. And here you can easily find out that monomorphic ventricular tachycardia, as all of you are saying, right. Not only that, supraventricular tachycardia with aberrant conduction can also causes this. Supraventricular tachycardia with pre-existing bundle branch block, that can also causes this, and there are many other polymorphic ventricular tachycardias also there. SPSVT can also cause. That's why we are saying here. Hyper or hypomagnesium can also causes. Hyperkalemia can also causes, and sodium channel blockade. So now you concentrate on this first one, right. So look at here. Question is, which of the following ion channel abnormality is most likely responsible for this ECG finding? Although the causes has listed that potassium problem, hyperkalemia can also causes wide QRS complex, but hyperkalemia is not the problem of the potassium channel. Getting my point? Hyperkalemia, if it happens due to certain reason, then they can causes widening of the QRS complex. So in this question, you cannot choose this potassium channel dysfunction as your answer. Okay, answer will be something else. Now try to understand. So we have already seen that the action potential of ventricular muscles looks like this. Okay, look at this. So in this action potential, you all know that this is the phase number 0. What is phase number 0? Depolarization phase, right? Then this is the phase number 1, then this is the phase number 2, and this is phase number 3. So phase number 0 is depolarization, phase number 3 is repolarization. What is this? This is an action potential recorded from a single myocardium cell. What is ECG? What is ECG? ECG is nothing but recording of the action potential from the whole heart, or you can say a group of myocardium cells. So that's why the ECG diagram is different from that of the action potential diagram, but both are the same electrical activity. The action potential is recorded from a single myocardium cell by placing one electrode inside the cell, and ECG is recording of the electrical activity from the heart surface, or you can say body surface. So ECG is nothing but electrical activity from group of myocardium cells. Now if I correlate this action potential and ECG, look at this. Look at this. So the ECG QRS complex correlates with the, so QRS complex in the ECG, what you know? QRS complex indicate ventricular depolarization, and in the action potential, which one is the ventricular depolarization? Phase number 0. That's why phase number 0, whenever it is starting in the action potential, QRS complex is also going to start in the ECG. And whenever there is phase number 3 in the action potential, then it is going to cause repolarization of the ventricular muscles. Repolarization in the ventricular muscle means T wave. That's why we say that the QRS complex of ECG directly correlates with the phase number 0 of myocardium, and T wave in the ECG directly correlate with the phase number 3 of myocardium. Getting my point? That's why you know that QT interval, you must have heard about this interval from the beginning of the Q wave up to the ending of the T wave, that is the QT interval. QT interval is directly equal to the action potential duration of the myocardium. Action potential duration of the myocardium, 300 to 400 milliseconds. Getting my point? This is the correlation between these two things. Now suppose if I give one sodium channel blocker, you know there are various anti-arrhythmic agents are there which blocks the voltage gated sodium channel in the myocardium. So whenever you are blocking voltage gated sodium channel, not 100% blockage will be there will be partial blockage. So what will happen? This QRS complex, which was very rapid in onset, this QRS complex will be slow in onset. So whenever the QRS complex is slow in nature, what will happen? The QRS complex is also going to be prolonged. Getting my point? So whenever your phase number 0 is rapid, your QRS complex is also rapid. But whenever your phase number 0 is slow, your QRS complex is going to be widened. That is the basic reason why whenever you give sodium channel blockade, the QRS complex is going to be prolonged. It is going to happen because whenever you are blocking the phase number 0, you are slowing the depolarization of the ventricular muscles, and whenever there is slowing of the depolarization of the ventricular muscle, the QRS complex is going to be widened. So even without understanding anything, if I have to answer these questions, whenever I am looking at this question, I am understanding that wide QRS complex indicated either the tachycardia is originating from ventricular muscle or maybe atrial muscles. So ventricular muscle or atrial muscles, the action potential is based on phase number 0, that is the sodium channel. So whenever there is problem in sodium channel, the QRS complex is going to be abnormal, widen. So easily you can answer that sodium channel dysfunction is going to causes this kind of scenario. Phase number 0 will take more time, yes, that is the reason, okay. So whenever your phase number 0 is taking long time, your depolarization will also be slow through the ventricle and it will be prolonged, QRS complex will be prolonged. Channel dysfunction related to TOF, that is the potassium channel. If the potassium channel is dysfunction, if the potassium channel is opening up quickly rather than normal, then QT interval will be shortened. But if the potassium channel is blockage, then this QT, okay, this action potential will be prolonged. Whenever your action potential is prolonged, your QT interval will also be prolonged. That is the simple concept, right? So whenever your action potential is becoming prolonged, suppose this potassium channel, which is supposed to be open up during phase number 3, you have blocked those potassium channels. So the slow repolarization will be there. Slow repolarization means repolarization will take long time. So the action potential duration will be prolonged, and that is equal to your QT. So QT interval will also be prolonged. That is the simple thing. Getting my point? So hyperkalemia can causes prolongation of the QRS complex, but not the potassium channel disorder, right? So that will prolong the QT interval, but not the QRS complex. I hope I am clear to all of you. Yes, that can leads to this, okay. So I hope this is clear to all of you. Question number 5 is discussed, okay. So beautiful questions. Next question, question number 6. So a 65-year-old male patient presented with congestive heart failure. So the problem has been given directly here, congestive heart failure, fluid overload and increased blood pressure. Obviously, congestive heart failure means there is going to be fluid overload and there will be increase in blood pressure due to this congestion of fluid, right? Which of the following hormone is primarily responsible for lowering of the blood volume and blood pressure in congestive heart failure patient? So in congestive heart failure patient, apart from this option number E, all other hormones, they are going to be elevated. All other hormone that is given here, they are going to be elevated. All of you know this, okay. Sorry. Yes, try to answer. Yes, correct, you are going in the correct direction. So look at here, all of these hormone that is given in these choices, they are going to be elevated in a patient of congestive heart failure, okay. But we all know that if the aldosterone is high, it is going to increase more sodium reabsorption. More sodium reabsorption means more water and there will be more blood pressure. So it is going to increase your blood pressure, increase your blood volume, not going to decrease. Vasopressin or ADH, it is going to reabsorb more water from the kidney. More water reabsorption means more blood volume, okay. More blood volume means it is going to increase your blood pressure, right. But look at here, atrial natriuretic peptide. We all know that atrial natriuretic peptide is released from the right atrium. That is the source of the atrial natriuretic peptide, right atrium. Whenever right atrium is stretched, so the patient is suffering from congestive heart failure. There is congestion mainly on the right side of the heart. So right atrium is going to be dilated, right atrium is going to be stretched. Whenever right atrium is going to be stretched, the atrial natriuretic peptide is going to be released in huge amount, okay. Now this peptide inhibit a ion channel that is known as the INI-CET channel at the level of kidney. INI-CET channel, this INI-CET channel, epithelial sodium channel, is responsible for sodium reabsorption from nephron. So if you inhibit this INI-CET channel, so sodium reabsorption will be lesser. So sodium is going to be excreted in the urine. Whenever sodium is excreted, water is also going to be excreted. So your volume is going to be decreased and your blood pressure is going to be decreased, natriuresis, right? So that's why answer of this question is option number C. Although epinephrine will also increase the blood pressure and we have blood volume, right? So all of you know the pathology of the heart failure. This is the diagram taken from Harrison. I am 100% sure that all of you have understood this diagram. So whenever the heart is not able to pump properly, so first there will be decrease in blood pressure. Whenever there is decrease in blood pressure, all of us know that the baroreceptor is not going to function. Yes, exactly, Dr. Rai, you are correct. So whenever heart is pumping less amount of blood due to failure, the blood pressure will decrease and that will leads to baroreceptor dysfunction. We all know when the baroreceptor is stimulated, when the blood pressure is high. When the blood pressure is high, if the baroreceptor is stimulated, it is going to suppress the sympathetic activity. That is a normal thing. But when baroreceptor is inhibited due to low blood pressure, what will happen? The sympathetic system is going to be activated. That is the first thing which is going to happen in case of heart failure patients. So baroreceptor is inhibited. Whenever baroreceptor is inhibited, there is a center at the level of medulla which is known as a vasomotor center. Okay, it is a center for sympathetic system. So this vasomotor center will be released from the inhibition of the baroreceptor, and the vasomotor center will be activated. That will lead to activation of the sympathetic system, and that is the main initiating event in the heart failure. So increased sympathetic activity will be there, and there will be increased vasopressin secretion. So this increased sympathetic activity will also produce increased amount of angiotensin II, because renin production will be high, right? So this renin secretion is high, angiotensin II production is also high. So what will happen? There will be increase in aldosterone secretion. Increased aldosterone secretion will leads to increased sodium reabsorption. Increased sodium reabsorption will increases the water content of the body, and that will leads to peripheral congestion gradually. So this is the whole process which is happening in case of heart failure patient, right? But here the question is asking that which hormone has some beneficial effect in the patient of heart failure. So we all know that whenever there is congestion of the right atrium, this right atrium is going to produce ANP, and ANP is going to causes natriuresis. Natriuresis means there will be excretion of the sodium. Along with the sodium excretion, there will be excretion of the water from the body, and the blood volume and blood pressure is going to reduce a little bit. So this is the question which they are asking here. I hope all of you understood. Now the next question, that is the question number 7. Right. So again a easy question, try to answer. Aldosterone has many action. INI-CET channel stimulation is also there. Sodium potassium ATPase pump is also stimulated. Potassium channel is also stimulated. So not only sodium reabsorption will be there, there will be excretion of the potassium in the urine also. Okay. So yes, you are absolutely correct. INI-CET channel will be stimulated mainly by the aldosterone. Now look at this question here, all of you. So 30-year-old female patient presented with episodes of lightheadedness and dizziness upon standing from lying position. So whenever you change your posture from sitting or supine, you are feeling a light headachehness. Okay. So whenever this kind of symptoms is given by certain patient, we think of some autonomic failure, means this baroreceptor mediated sympathetic and parasympathetic system, they are not working properly. So the disorder is labeled as the orthostatic hypotension, okay, or postural hypotension. But there is a particular definition of postural hypotension or orthostatic hypotension. Okay, there are difference between various literature. What is the definition of orthostatic hypotension? But this is clearly given in Harrison. So there are other literature which is saying slightly different. But look at here what is written in Harrison about orthostatic hypotension. So orthostatic hypotension is defined as the reduction in systolic blood pressure of at least 20 millimeter of mercury, or diastolic blood pressure at least 10 millimeter of mercury. So whenever you are changing your posture from supine to standing, if your systolic blood pressure is decreasing more than or equal to 20 millimeter of mercury, and diastolic blood pressure is decreasing more than or equal to 10 millimeter of mercury at 3 minutes. Okay, so you have changed your posture, and then you are, after changing this posture, you are measuring the blood pressure at 3 minutes. Some of the literature is saying that within 3 minutes, if any drop of blood pressure is more than 20 or more than 10, that is orthostatic hypotension. But Harrison is clearly giving this after 3 minutes of standing or head up tilt on a table. So there are certain table which are available in certain department, like in our department there is an autonomic lab where there is a tilt table where the patient or subject will lie down, okay, and then the table will move from lying down to supine posture rather than the patient is actively moving from supine to standing. Okay, so this is a passive table which is tilting the subject from supine to standing. But anyway, after standing, after changing the posture, at 3 minutes you record the blood pressure. If the systolic blood pressure is falling more than 20 or equal to 20, or diastolic blood pressure is greater than equal to 10, then the subject will be labeled as that the subject is suffering from orthostatic hypotension, and mostly it indicate autonomic failure. Okay, Parkinsonism patient, other autonomic dysfunction patient will have this kind of orthostatic hypotension. So in this question, if you look at here, okay, so in this question, if you are looking here, so supine blood pressure is this and heart rate is this. After standing for 3 minutes, the systolic blood pressure is 100 and diastolic blood pressure is 60, right. So you can easily find out that the systolic blood pressure fall is 20 or more at 3 minutes, okay, and diastolic blood pressure is more than 10 millimeter fall. So this is a clear case of orthostatic hypotension. But the question is not asking about that. Even if you don't understand this whole thing, the question is simply asking a simple physiology, that which of the following is responsible, primarily responsible for the drop in blood pressure upon postural change. So we all know that whenever you are changing your posture from supine to standing, immediately what is going to happen, there will be venous pooling in the lower part of the body. Okay, okay. So there will be venous pooling of blood in the lower part of the body. Approximately, it is said that approximate 500 ml of blood will be pooled in the lower part of the body. Okay, means your legs and your abdominal veins, in all this region there will be pooling of blood whenever you are changing your posture from supine to standing. Now whenever you pooled more blood into the lower part of the body, what will happen? Less blood is going to return on your right side of the heart, so there will be decrease in venous return. There will be decrease in venous return because of this pooling of blood in the lower part of the body. So this is the initiating event, pooling of blood in the lower part of the body. That will reduce the decreased venous return, and whenever there is decreased venous return to the right ventricle, the right ventricle is going to pump less amount of blood, means cardiac output will fall. So this will leads to decrease in cardiac output. Decreased cardiac output will also decrease the blood pressure. So this is the reason why the blood pressure falls when you change your posture. But this fall of blood pressure is not very significant, or even if this blood pressure fall is significant, our normal body is going to correct this fall of blood pressure easily. Why? Whenever there is fall of blood pressure, look at carefully, okay, whenever there is fall of blood pressure, could you tell me what will happen to the baroreceptor? Baroreceptor will be activated or inhibited. If there is fall of blood pressure, within 8 to 12 seconds, means within second, your baroreceptor is going to be inhibited. Just I told you in the previous discussion also, baroreceptor will be stimulated when the blood pressure is high, but whenever your blood pressure is lowering down, because you have changed your posture, your baroreceptor is inhibited. And if your baroreceptor is inhibited, just now we have seen what is going to happen. It is going to release the vasomotor center from inhibition. That means vasomotor center will be activated, and I told you vasomotor center is directly connected with the sympathetic system. So the sympathetic system of your body will be activated. So whenever you change your posture from supine to standing, immediately your blood pressure will fall, but within 8 to 10 seconds your baroreceptor will be inhibited. Because of the inhibition of the baroreceptor, your sympathetic system will be activated, and sympathetic system activation means we all know that it is going to increase the contractility of the heart. Heart will pump more forcefully. Whenever the heart is pumping more forcefully, your cardiac output will be increased. Sympathetic system is also going to increase increase your heart rate. So your heart rate is high, your cardiac output is high. So what will happen to your blood pressure? We all know the blood pressure is the combination of these two things. So the blood pressure is going to rise immediately, means within few seconds, maximum within minutes, the blood pressure will be increased and it will stabilize to a normal level. Getting my point? Okay. And all the blood which was pulled in the lower part of the body, because of this sympathetic activation, sympathetic system will causes vasoconstriction. Vasoconstriction means it will pump all the blood which was pulled in the lower part of the body, and that will increase the venous return. So all this thing is happening because of the baroreceptor inhibition. Because of the baroreceptor inhibition, and because of the baroreceptor inhibition, your sympathetic system is overactive. So means sympathetic system is a part of the autonomic system. So if this sympathetic system activation is not there, then all this thing is not going to happen. All these things is not going to happen. And what will happen in that case is the blood pressure will remain to a low level for long duration, maybe up to 3 minutes, and that will causes the postural hypotension. Getting my point? So whenever your blood pressure is lowering down because of the change of posture, your baroreceptor is inhibited, and baroreceptor inhibition means your sympathetic system will be activated. If your sympathetic system is properly functioning, your blood pressure will raise to a normal level within few seconds or maybe within 1 minute or 2 minutes maximum. But at 3 minutes, if your blood pressure is still lower, it is not corrected, that indicates that sympathetic system or the autonomic system is at failure. That's why I was talking that orthostatic hypotension indicates autonomic failure in most of the cases. Now we got it. So now after understanding this, the question is very simple. They just ask which of the following is primarily responsible for the drop of blood pressure in postural hypotension. So we told venous pooling leading to decreased venous return. So the decreased venous return is the main thing which is going to causes postural hypotension. Although decreased venous return will lead to decreased cardiac output, but they are saying which is the initiating event. So initiating event is the decreased venous return. Okay. Impaired baroreceptor reflex is cause of postural hypotension, but this is not the initiating event. Am I clear to all of you? Tell me whether you understood this question or not. Very important question for your future MCQ. All of you tell me whether you get it or not. Okay? Dr. Devi has already told. Yes, thank you so much. Okay. Now next question. Next question here. Very good, very good, very good. Thank you for the answer. Okay. Now next question here. Thank you. During an infection, there is an increase in production of leukocyte to fight against pathogen. Which of the following cytokine is primarily responsible for stimulating the production of leukocyte in the bone marrow, right? So WBC production in the bone marrow, which of the following cytokine? So this is a purely memory based question. Okay. And most of the cases these questions are difficult because interleukins is very difficult to remember, for my cases at least. Okay. So when I was looking at this question, I was thinking either it will be answer is interleukin 1 or interleukin 6. But when I search for the books that which interleukin is responsible for stimulating the production of leukocyte in the bone marrow particularly. Okay. WBC series is mainly stimulated by which cytokine? That is the main question here. Okay. So interleukin 1 or 6, ये दोनों में से हम लोग को decide करना होगा. So now look at what hematology textbook is saying. So these are the line which I have taken from Winthrop textbook of hematology. So first of all, you have to remember that there are certain cytokines which stimulate the hematopoietic stem cells or progenitor stem cells. Okay. At least you try to remember these cytokines. This is directly taken from hematology book. So there are certain cytokines which stimulate the hematopoietic stem cell or progenitor stem cell. Multi-lineage potential means they can stimulate any series of cell, right? So what are those cytokines? KIT ligand, very, very important. GM-CSF, you all know, colony stimulating factor. GCSF, CSF1, interleukin 3, interleukin 4, interleukin 6, 11, 12. a leukemic inhibitor factor, and oncostatic M. At least you remember the interleukin which stimulate the hematopoietic stem cells. So, what are those? Interleukin 3, interleukin 4, interleukin 6 and interleukin 11 and 12. Remember this, okay. Not much understanding, but try to remember. Now, look at within this interleukin, there are certain interleukin which stimulate specially the granulocyte colony, means WBC का जो granulocyte series है उसको stimulation देने के लिए, that is the GCSF, GMCSF, interleukin 6, interleukin 3, okay, stem cell factor and colony stimulating factor 1. So, please remember at least this second line to answer the question which has been asked here. So, mainly the granulocytic series okay, of WBC production will be increased in presence of interleukin 6 and interleukin 3, right. So, if I look at the question once again, here the interleukin 6 is going to be my main answer. That is the answer here, okay. Interleukin 3 can also be answer, interleukin 6 can also be answer, but here interleukin 3 is not given, so interleukin 6 is going to be my answer. That is the only explanation for this question. You try to remember at least these cytokines for your future MCQ, right, okay. Next question. Next question here, question number 9, okay. So, a 50-year-old male patient presented to the emergency department with a deep laceration on his forearm after an accident. Upon examination, bleeding from the wound is persistent and difficult to control. Okay. So, it is a bleeding disorder, I can understand. Laboratory test reveal normal platelet count. Okay. So, platelet count decrease हुआ है, it has been ruled out. Okay. But prolonged bleeding time. Okay. So, in first year MBBS, you in practical, hematology practical, bleeding time and clotting time कैसे किया जाता है, we generally teach the student, okay. Bleeding time, how it is tested, and clotting time, how it is tested. So, this question is purely from the bleeding time. Although the bleeding time and clotting time, it has less value in bleeding disorder patient, because you have to ultimately do the prothrombin time, activated partial thromboplastin time and other parameter. But anyway, the question is here about prolonged bleeding time, right. So, whenever there is a question of prolonged bleeding time, we have to first think of primary platelet plug formation, primary platelet plug formation. All of you know that whenever there is injury to the blood vessels, the first thing that is going to happen is the primary platelet plug formation. So, what is that? This is the vessel wall, okay. Suppose this is the vessel wall, the platelet is going to adhere on this vessel wall, then they are going to activate, and then they are going to aggregate, and it is going to form a plug at the site of damage, blood vessel damage. All of you know this thing, all of you know this thing. So, if there is any problem at the level of this blood vessel wall or any problem at the level of this platelet, then it is going to increase your bleeding tendency from this vessel, and in these cases the bleeding time, the BT, is going to be prolonged. That is a very simple thing. So, either platelet problem, what may be the platelet problem? Suppose there is severe dengue and platelet count is reduced, thrombocytopenia due to any cause, okay. But here in these cases, the platelet count is normal, that is already told. So, platelet count is normal, but platelet can be abnormal functionally, their receptor can be abnormal, okay. GP2B, GP3A, okay, that receptor can be abnormal, the activation of the problem, platelet can be abnormal. So, functional abnormality of platelet can also increase bleeding time, or if there is problem in the vessel wall means there may be problem in the collagen, like for example in case of scurvy, which is going to happen, or there may be problem in certain factor which are there in the endothelium wall, like for von Willebrand factor. If that is also deficient, then this whole process will be problematic and bleeding time will be prolonged, right. So, what we are going to remember in this question, that bleeding time normally is less than 3 minutes when it is tested by Duke's method, and there is another method for testing the bleeding time, that is known as the IV's method. In that cases the bleeding time is less than 8 minutes. Try to remember this, first year MBBS practical. Bleeding time generally we perform by Duke's method, in that cases it is less than 3 minutes. But if you perform the bleeding time by IV's method, it is less than 8 minutes. Prolonged bleeding time indicate, the first thing that is written here is the thrombocytopenia, but that has been ruled out in this question. Second, is the von Willebrand disease. All of you know that von Willebrand factor, it is helpful for addition of the platelet, right? So that is the second most common. Third is the DIC, disseminated intravascular coagulation. All of you know the platelet will be consumed in huge amount, and that will also leads to prolonged bleeding time. And then two disorder, important disorder, all of you know that the Glanzmann's thrombasthenia and Bernard-Soulier syndrome. All of you know the which receptor in the platelets problem in this disorder from your medicine knowledge. And fifth one is the platelet function inhibitor medication, means if you are taking aspirin, clopidogrel or this medication, they also increase the bleeding time. So the first problem, the first is thrombocytopenia, that has been ruled out here. So the second most common is the von Willebrand disorder. That's why in this question we are going to choose impaired von Willebrand factor function, that we are going to choose in these cases. Although decrease in the platelet addition can also increases the bleeding time. This is also true. Defective platelet aggregation, this can also increase the bleeding time, right? Reduced platelet granule secretion, this can also increases the bleeding time, okay? All of this can be causes of increased bleeding time, but I have to choose one most common cause in this question, and according to this question, the impaired von Willebrand factor function is my answer, right? So this is answer of the question number 9, okay? Chalo, next question. So the next question here is question number 10. 45-year-old male with liver cirrhosis, okay, with ascites. So liver cirrhosis with ascites, and you are finding out there is decrease in GFR, glomerular filtration rate. Which of the following mechanism is primarily responsible for decreased GFR in this patient? That is a simple question, okay. So if you look at the options, activation of the sympathetic nervous system, it is going to happen in case of cirrhosis patient, true. Release of renin from the juxta, this is also true. Constriction of the afferent arteriole, this is also true. Increased release of aldosterone, this is also true. Vasodilation of the efferent arteriole, this is also true. So all these things can happen in case of ascites patient, which is who is suffering from cirrhosis, you know, the okay. So you are answering, okay, any of them can be answered, but which is going to causes decrease in GFR directly, that you have to choose, because every option in this question is true about this patient, okay. First you look at this pathology. So this is one schematic diagram which is showing what is the cause of ascites in case of cirrhosis patient, taken from a journal article. So here cirrhosis with liver dysfunction, it will produce portal hypertension. Whenever there is portal hypertension, the blood flow velocity through these constricted vessels will be high, that will cause a shearing stress on the endothelium. That shearing stress is going to produce vasodilator. So there will be increase in production of the various vasodilator. That vasodilator is going to causes dilation of the arterioles. Which arterioles? Mainly the splanchnic. Mainly the splanchnic arterioles will be dilated. Now whenever your splanchnic arterioles are dilated, what will happen? There will be increase in volume into these blood vessels, and that will start producing fluid accumulation in the peritoneal space, right? Not only that, this increased blood vessels at the level of splanchnic arterioles, what will happen? More blood will be diverted to the splanchnic circulation. What will happen to your systemic blood pressure? So more blood is delivered, more blood is diverted to the splanchnic arteriole due to dilatation of the splanchnic arteriole due to production of vasodilator. What will happen? Less blood will circulate through your other part of the systemic circulation, means blood pressure will be decreased. And whenever your arterial blood pressure is decreased, okay, in case of ascites patient, this will activate the sympathetic system, again the same mechanism, by release of inhibition of the vasomotor center. And whenever your sympathetic system is activated, so there will be increase in sympathetic system activation. This sympathetic system activation will also increase the renin angiotensin system activation, that will increase the production of aldosterone. This aldosterone is ultimately going to retain more amount of sodium, more amount of water in the body, and that is going to increase the plasma volume, and that increased plasma volume is again going to produce more ascites. And on the other part, Whenever there is portal hypertension, the splanchnic capillary pressure will be increased because of the vasodilation. Capillary pressure is high. More capillary pressure means more lymphatic dilatation will be there, more lymph formation will be there, and that lymph formation will again produce ascites. So now we can understand that in case of liver cirrhosis patient who is suffering from ascites, sympathetic system will be activated. Sympathetic system activation will leads to constriction of afferent arterioles, and whenever your afferent arteriole is constricted, your GFR is going to be reduced. So the main answer that we are going to give here is option number C, that is the constriction of the afferent arteriole. Okay, there will be activation of the sympathetic system, but sympathetic system activation is going to reduce your GFR. But look at the other options. Is there any direct cause which is directly related to the GFR? Obviously, sympathetic system activation is going to reduce your GFR. But look at the other options. Is there more appropriate option in this question? Answer is yes. How sympathetic system reduces GFR? If I ask you, constriction of the afferent arteriole. Is it there in your answer? Is it there in your option? Answer is yes. So why not to choose that? So that's why we are choosing here the option number C. Otherwise, I told you already, this A is also going to be your answer. Okay? This release of renin from the juxtaglomerular cell, that is also true in case of cirrhosis ascitic patient. Increase aldosterone, that is also true. Okay? But I have to look at which one is going to causes decrease in GFR directly. Sympathetic system activation. How? By constriction of the afferent arteriole. So the best answer to choose in this question is option number C, not the A. Got it? So very beautiful question, good questions. You have to read all the options and then try to answer. And in between, if you get time, try to look at this pathogenesis of the ascites in case of cirrhotic patient. I believe you all know from your medicine knowledge. Now next question. So question number 11 here. Which of the following statement best describe the role of counter current mechanism in urine concentration? Now this is a direct question. Try to answer. Then I will look at that whether you are giving correct answer here or not. So this question I am not going to discuss in detail. Which of the following best describe the role of counter current mechanism for urine concentration? How counter current system is going to concentrate your urine? All of you know that counter current system is going to increase the tonicity of the medulla. It is going to increase the tonicity of medulla of the kidney. So increase medullary tonicity. How the medullary tonicity will be increased? If this is the cortex and if this is the medulla, from the cortex towards the medulla. Suppose this is the cortex part of the kidney and this is the medullary part of the kidney. If you look at the increased tonicity, the tonicity is not increased at the level of cortex, but if you enter from cortex towards the medulla, more you enters towards the medulla, the tonicity will be more and more higher. So suppose tonicity here is 400 milliosmol per liter, it will be 600 or 500, maybe here it is 800, maybe here it is 1000, maybe here it is 1200, like this. So there is increase in tonicity, there is increase gradation of tonicity from cortex towards the medulla. So the best answer in this question, it helps to establish a concentration gradient along the entire length of nephron. So the nephron will be present like this, from cortex the nephron will be present like this. So towards the medulla, from cortex towards the medulla, there will be increase in concentration gradient. Is facilitate the reabsorption of water from collecting duct? This is not true, my dear. It not only facilitates the absorption of water from collecting duct, but also from the descending limb of loop of Henle. Getting my point? Why C is not correct? Suppose this is the nephron, right? And this is the descending limb, this is the ascending limb of loop of Henle, this is the collecting duct. I hope you understood this diagram. So whenever there is increased tonicity, suppose this is 300, this is 400, this is 500, this is 800, this is 1000, right? This is 1200. Whenever solute is flowing through this descending limb of loop of Henle, the water will be reabsorbed from this part also. So this is the descending limb of loop of Henle. Why the water is reabsorbed? Because of the increased tonicity of this medulla. So the counter current system is increasing the tonicity of the medulla. Because of the increase in tonicity of the medulla, water reabsorption is happening from the descending limb of lobe of Henle as well as from the collecting duct. So here it is saying only from collecting duct, that's why this is partially correct, right. So that's why C is not the answer. Actively pump solute out of the urine, this is absolutely wrong. Actively pumping of solute is not due to the counter current system. Counter current system is due to generation of the tonicity of the medulla. How that tonicity is generated? By pumping out of sodium and chloride. So because of the tonicity, sodium and chloride is pumped out? Not. Because of the pumping out of the solute, the tonicity will be generated. Yes, the water is mainly there for ADH mediated, but again that is also part of the counter current system, okay, because in counter current system urea is also there, and urea will increase also the tonicity, that will also helpful for the water reabsorption. But again, you are absolutely true that water reabsorption in the collecting duct is purely based on the ADH. If the ADH is not there, water reabsorption is almost nil, only 2% Kaspas, right. So that's why the option that we have chosen here. Okay. Now next question, question number 12. Okay. Now this is a direct question, try to answer. Okay. So they are simply asking that a 55-year-old male patient brought to the emergency department after traumatic brain injury. On examination, the patient is unconscious and requiring mechanical ventilation, means the automatic ventilation system is damaged. Automatic inspiration and expiration system is damaged, that's why you are giving mechanical ventilation to this patient. The physician suspect damage to a specific brain area responsible for the automatic breathing generation. So we all know that the question is asking about the pacemaker of respiration, and pacemaker of respiration is known as the pre-Borginger complex. Pre-Borginger complex is located at the level of medulla, right. So all of you know this direct answer, so I am not discussing detail about this. So this is the respiratory central location. So there is ventral respiratory group of neuron VRG, and there is dorsal respiratory group of neuron. Within this VRG, this pre-Borginger complex is there, which is known as the pacemaker of respiration. This is the only thing that you have to remember in this question. Okay. Next question. Next question is here. During exercise, the demand of oxygen increases. How does this increased demand affect the rate of oxygen diffusion across the alveolar capillary membrane? Read the question carefully, you will be able to answer. So the question here is, suppose this is the alveoli and this is the capillary of the lung. Okay. So this is the venous blood coming here at the level of this lung or alveoli, and then there will be diffusion of oxygen from this alveoli to the blood. In case of patient who is doing an exercise, what will happen? The muscle will utilize more oxygen from the arterial blood. So what will happen to this oxygen content of the blood? It will be low. It will be lower than normal. Okay. So the person who is doing exercise, muscle is extracting more oxygen from the arterial blood. What will happen to the oxygen content of the venous blood in comparison to normal person? There will be low. Okay. So the blood, the venous blood which is reaching at the level of this lung, it contains low oxygen tension. That is the first thing. Second, the person who is doing exercise, what will happen to the ventilation of this person? What will happen to the ventilation of this person? If you do exercise, you are going to hyperventilate like this. Whenever you are hyperventilating, you are taking more oxygen into your lung. So more oxygen is entering in your lung, means oxygen tension is high inside the lung, and oxygen tension is low in the venous blood, means oxygen tension is low in the blood and high in the alveoli. So what is going to happen? It is going to increases. Okay. So look at that, it is going to increase the partial pressure gradient of oxygen. So what do you mean by partial pressure gradient? Gradient means difference of pressure. Partial pressure gradient between alveoli and venous blood, alveoli and capillary blood. So it is going to increase the partial pressure gradient between alveoli and capillary blood. Okay. So alveolar partial pressure of oxygen is increasing and capillary partial pressure is low due to exercise. So the first or option A is going to be my answer. Decreased thickness of the membrane is not going to happen. Increased solubility of the oxygen is not going to happen. All these parameters are almost constant in the lung. Decreased surface area of the membrane, decrease is not going to increase the diffusion. Decreased surface area means there will be decrease in diffusion. It is not going to happen in exercise. It has no effect on rate of oxygen diffusion is a absolutely false statement, right? Yes. So option A is correct here. So 30 number question, A is the correct answer. Next question. Next question here is peristalsis is a coordinated contraction and relaxation of the muscles that propel the material through the gastrointestinal tract. Tell me the answer. Which of the following is primary mechanism responsible for initiation of peristalsis? So all of us know that what is peristalsis? So peristalsis means whenever food bolus is reaching a part of the GIT. Suppose this is the food bolus, this is the food bolus has reached a part of the GIT. What it going to do? It is going to stretch the intestinal lumen. So it is going to produce stretch on the intestinal lumen, and this stretch is going to be sensed by certain cells of the GIT which is going to produce serotonin. Okay. And this serotonin is going to act on the enteric nervous system, and this enteric nervous system is going to causes relaxation of the distal part and constriction of the proximal part. So the first thing is stimulation of the mechanoreceptor. So the first thing that is going to happen is the stimulation of the mechanoreceptor in the gastrointestinal wall. Very good, right? So look at the complete mechanism here. So this is the diagram taken from a journal article, very simplified diagram. So this is the enterocyte. This is the location of enterocyte, right? So the food bolus is here. Food bolus is here. It is going to cause a stretch on this enterocyte. This enterocyte is going to produce serotonin 5-hydroxytryptamine. That is going to act on a neuron. That neuron is going to produce CGRP, okay, calcitonin G related peptide. And that CGRP producing neuron is going to activate certain neuron in the distal part which is going to produce VIP and nitric oxide. Along with this VIP and nitric oxide, PACAP is also there, and it is also going to produce acetylcholine and substance P in the proximal direction. So this is going to cause constriction of the proximal part, and this acetylcholine, nitric oxide VIP is going to cause relaxation of the distal part. This is the basis of peristalsis, right? So all of you know this neurotransmitter because they have been asked multiple times. Now you know the complete mechanism. That food bolus is going to produce serotonin, serotonin is going to stimulate the enteric nervous system, and then one side acetylcholine and substance P, on other side VIP and nitric oxide. That is peristalsis. I hope this is clear to all of you. Next question here, question number 15. A 60-year-old male with pernicious anemia presented with fatigue and tingling sensation. So whenever this question is given, all of you know that pernicious anemia is a kind of megaloblastic anemia, and why that megaloblastic anemia is going to happen due to deficiency of the vitamin B12, and vitamin B12 reabsorption require one intrinsic factor. That is the question which is asked here. So that intrinsic factor is produced by which cells? That they are asking in this question. So I am 100% sure all of you know that intrinsic factor is produced by parietal cell. Intrinsic factor is produced by parietal cell. In case of pernicious anemia, the basic pathology is antibody will be directed towards this parietal cell, and that's why the parietal cell will be destroyed, and because of the destruction of the parietal cell, acid production in the stomach will be reduced, as well as intrinsic factor production will also reduce. Because of the decreased intrinsic factor production, the vitamin B12 reabsorption will be less, that will produce megaloblastic anemia, right? So these are the various cell types which are going to produce various secretion in the stomach. You know, parietal cell, or also known as oxyntic cell, they produce acid and intrinsic factor. Chief cell, that is also known as peptic cell, they are going to produce pepsinogen. The other cell you also know, G cell is there for the gastrin production, right? D cell is also there for the somatostatin production, like this. So, these are the different cells in the stomach. Okay. So, this is a simple question, I am not going to discuss more detail. So, next question here. Okay. Now, this question is a direct question, read the question and try to answer. So, 55-year-old male presented with loss of pain and temperature sensation. So, the first hint is here, loss of pain and temperature sensation. Okay. Then a detailed history has been given due to sudden fall and everything. Physical examination reveals intact proprioception and light touch sensation. So, whenever it is said that intact proprioception and light touch sensation is there, that means dorsal column is intact, dorsal column is normal, right, normal, but pain temperature system is damaged. And we all know that pain and temperature is carried by lateral spinothalamic tract, lateral spinothalamic tract, which is a part of the enterolateral spinothalamic tract. So, all of you can give correct answer in this question, enterolateral spinothalamic tract is going to be my answer, right. So, simple question, direct answer, no further discussion. Next question, which somatosensory receptor is most abundant in the fingertips and lips, providing high spatial resolution? Okay. So, whenever the question is about touch sensation, okay, which of the following somatosensory receptor is most abundant? Most abundant means it is always the Meissner's. Okay. So, this is a direct question, huge amount of Meissner's corpuscles as well as the Mertels are present at the level of your fingertips and all. So, Meissner's, if the question is most abundant or maximum number of cutaneous somatosensory receptor, particularly touch receptor, your answer is Meissner's. Okay. So, no further discussion, this is a direct question, your direct answer is Meissner's corpuscles. Okay. Fine. Next. Okay. So, again you are going to answer this question, easy question. So, 65-year-old female presented with a medical history of osteoporosis. She recently underwent a bone density that reveals significant bone loss. Okay, volume is coming low. Okay, okay, देखते हैं. So, considering her condition, which of the following hormone act directly on the bone to inhibit osteoclast activity? So, although there is a clinical history in this question, but the question is direct. Question is direct means they are asking which of the following hormone act on osteoclast. So, we all know parathyroid hormone and vitamin D, both of them has receptor on osteoblast. The osteoclast activity is inhibited by a hormone which is nothing but, yes, calcitonin, right. Calcitonin. Calcitonin causes apoptosis of osteoclast. This is the only thing that you have to remember. Calcitonin causes apoptosis of osteoclast, and because of the apoptosis of the osteoclast, what is going to happen? Bone resorption will be inhibited, and bone resorption inhibited mean blood calcium will be lower down. Otherwise, if the parathyroid hormone is high, if the vitamin D is high, they are going to cause bone resorption. High vitamin D can also cause bone resorption. Parathyroid can also cause bone resorption. Bone resorption means bones will be more fragile and bones calcium will ooze out in the blood and blood calcium will be increased. But it is the calcium, it is the calcitonin which is going to prevent bone resorption by causing apoptosis or killing of osteoclast cell. So, whenever your osteoclast is inhibited, okay, bone resorption will be inhibited and your calcium in the blood will be lowered down. All of you know this. So, calcitonin is answered in this question. Next question, question number 19. Now, this is a question which is a little tricky, which is a little difficult, okay, but it is given in Genong. Okay. Now, I am telling you what is given here. The patient history is a history of a diabetic patient who has uncontrolled diabetes mellitus. Uncontrolled diabetes mellitus. But the question they are asking here, dysfunction of which of the following neurotransmitter involved in regulation of insulin secretion that may contribute to diabetes mellitus. Dopamine has also role, norepinephrine has also role. Norepinephrine, dopamine as well as acetylcholine, all these three neurotransmitters, they has prominent role on insulin secretion. But the question is dysfunction of which neurotransmitter, that is the catch here. So, you have to look at what is the function of acetylcholine on insulin secretion and what is the role of these catecholamines on insulin secretion. That is the only thing you have to understand here, right. So, look at what it is said in genome. Acetylcholine, okay, look at here. Acetylcholine, it acts on the M3 and M5 receptor on beta cell of pancreas. Okay. Acetylcholine is released from the alpha cell, nearby alpha cell, although that is for glucagon, but here alpha cell can also release a certain amount of acetylcholine. That acetylcholine is going to act on the beta cell. So, try to remember the beta cell, which receptor is going to be stimulated, main M3. So, acetylcholine is going to stimulate the M3 receptor and insulin secretion is going to be enhanced by acetylcholine. But also look at that this acetylcholine, which is released from the alpha cell, it is also stimulating the delta cell and delta cell produce somatostatin. So, if you stimulate the delta cell, somatostatin production will be increased, somatostatin is going to inhibit this beta cell, so insulin production will be decreased. Means acetylcholine is directly stimulating the beta cell for insulin secretion increment. Acetylcholine is also stimulating the delta cell and through the delta cell insulin secretion is going to be reduced. But what is the net effect? Remember, the net effect of acetylcholine is increase insulin secretion from beta cell of the pancreas, means direct effect is the dominant. So, if there is dysfunction of this acetylcholine neurotransmitter, dysfunction, this has been proven by experiment that if the M3 receptor is mutated, then the person, not the person, actually the experiment has been done on animal. If the M3 receptor is mutated on the beta cell of the pancreas, the animal is going to suffer from severe diabetes mellitus. That is proving the role of acetylcholine. So, acetylcholine has net effect on increased insulin secretion, and if that dysfunction of that acetylcholine receptor is there, then the person is going to suffer from severe uncontrolled diabetes mellitus, although the cases is rare, right. Now, look at here, what is the role of norepinephrine? You are going to answer the dopamine, norepinephrine, okay. So, if there is increase in CAMP, cyclic AMP by beta adrenergic stimulation or due to any reason, then insulin secretion will be increased. So, whenever you are giving catecholamines, it is going to stimulate alpha 2 receptor which is present on the beta cell, it is also going to produce beta adrenergic receptor. So, if alpha 2 adrenergic receptor is stimulated, then there will be increased CAMP. So, increased CAMP will stimulate the insulin secretion, and if the beta adrenergic receptor is stimulated, there will decrease CAMP and the insulin secretion will be decreased. Means again, this catecholamines has dual effect on insulin secretion. In one way, it is trying to increase the insulin secretion, and in other way, it is trying to decrease the insulin secretion. But question is, which one is the net effect? The net effect of catecholamines on insulin secretion is decrease insulin secretion. So, please remember this net effect even if you forget the receptor detail and all. So, acetylcholine net effect is increase insulin secretion. Catecholamines, the net effect is decrease insulin secretion. So, now if you look at the question is asking dysfunction of which of them is directly related to uncontrolled diabetes mellitus. The most probable answer is acetylcholine. Getting my point? Okay. Getting my point? So, acetylcholine is going to stimulate the insulin production. If there is mutation of this acetylcholine receptor on the beta cell of the pancreas, then insulin secretion will be reduced and that can lead to uncontrolled diabetes mellitus. Okay? Got it? That's why I was saying that this question is a little bit tricky, little bit difficult, but in Genome it has been given in a small paragraph, but that is difficult. But this diagram I have taken from journal article for quick understanding of this question. That is the thing you have to remember here. Now, the last question for today is, okay. So, which of the following factor contribute to an increase in ventilation perfusion ratio in the apex of the lung? I think all of you are going to give correct answer in this question. So, all of us know When the person is in sitting posture or in standing posture, the ventilation is maximum at the base of the lung. The perfusion is also maximum at the base of the lung. Okay. So, if the question is ventilation is maximum or perfusion is maximum in which part of the lung, in a standing person, in a supine in a upright posture, in an upright posture, okay, ventilation is maximum in the base, perfusion is also maximum in the base. But ventilation perfusion ratio is maximum at the level of apex, right? We all remember this. So, ventilation is maximum at the base, but if you reach at the level of apex, ventilation will also reduce, perfusion will also reduce due to the effect of gravity. So, if you move from base towards the apex of the lung, your ventilation will gradually reduce towards the apex. So, ventilation is also less, perfusion is also less at the level of apex, but if you look at denominator and numerator of this ratio, ratio is division of two number. So, perfusion reduces much more than that of the reduction of ventilation. If both ventilation and perfusion is reducing proportionally at the level of apex, then the ratio is not going to change. But whenever I am going from base towards the apex, ventilation is also lower, perfusion is also lower. Now I am looking at this ratio, denominator of the ratio, that is the perfusion, that is reduced much more than that of the ventilation. Now whenever in a ratio the denominator is more reduced than that of the numerator, what is going to happen? The ratio is going to become high, not only high, it is the highest. That's why we say that due to the effect of gravity, the ventilation is maximum in the base, perfusion is also maximum in the base, but ventilation perfusion ratio is maximum at the level of apex. So, this is the concluding statement for today's session. I hope all of you have understood these questions. So, the questions are clinical oriented. I told you if the questions is going to be next pattern or whatever type of exam pattern, the physiology questions will be clinical oriented questions, and all these questions that I have discussed here, this is the part of the question bank of PrepLadder, the clinical question bank of PrepLadder. And to access this clinical question bank, the PrepLadder has recently introduced a pro plan, okay, where you are going to get this whole question bank. Not only that, you are also going to have access on the treasures, and you are also going to have the access of test series and previous year questions, right? So, the plan is for 6 months and the price is also given, and this question bank is very crucial because we don't know what type of question is going to be asked in the next pattern, but this is the type of questions they are going to ask in the next pattern of question, clinical touch question, clinical oriented questions. So, I hope this session is beneficial for you. You have understood certain topic and you get some information in physiology topic. So, this is all for today's session. Thank you so much. Take care. Bye bye. Okay. Thank you.